I've had a lot of requests to discuss LPR, which stands for a type of acid reflux, but it's atypical. So first of all, the L is your larynx, which is your voice box, and the P is for pharynx, which is your throat, and then the R is for reflux. So this is called laryngopharyngeal reflux, and what's different and unique about it is that it's happening above your esophagus into your throat and voice box. Therefore, the symptoms are very, very different, which is why it's very highly misdiagnosed, and that's what I want to discuss, because it can be very frustrating to have a chronic cough, or you feel like something's stuck in your throat, or you're constantly clearing your throat, you're hoarse, you feel like you have a postnasal drip, almost like you're sick or you have an allergy. People describe it, well, having a sore throat, difficulty swallowing, again, lump in your throat. And I very much remember a patient who came in and she's just like, she was so frustrated. She said, there's just something stuck, there's something stuck, there's something stuck. I've been to ENTs, I've made them go in there and look, and I've had scans, and nobody can find what's stuck in my throat. And this is going back probably about 15 years now, but when we treated her for hiatal hernia syndrome, it all cleared up. But it was just making her crazy, because you can just literally feel like there's something stuck, or any of the other symptoms that I mentioned. So why it's unique is, let's do a little anatomy lesson. Your esophagus has two sphincters or valves, that an upper and a lower. And when they detect you drinking or eating, they open, they're very clever, and then once the food or drink has gone by, they close, and that happens in your upper esophagus and your lower esophagus. So kind of the guard that's preventing acid from going up into your throat and voice box is your upper esophageal sphincter. So it is deemed that with laryngopharyngeal reflux, that sphincter isn't working properly. And that's what we see in classic reflux, but we talk about the lower esophageal sphincter. So the mechanism is very much the same. The problem comes in because the symptoms are so different, and these patients don't have the classic reflux. They're not saying they have burning in their chest, they're not tasting acid. So I've done a couple of deep dives into this, and it was trying to understand why could acid, obviously the stomach is at the bottom of the esophagus. So how could acid travel all the way up your esophagus and now up into your throat and your voice box and not create any classic symptoms? So I thought, and if you follow this channel a lot, you will have heard me say, and I am now correcting myself, I thought it was just sort of a slow trickle, and it wasn't enough to create the classic symptoms. What they're saying now, well, they didn't say actually fast or slow, they said brief, so it could be brief and slow, but that one of the major differences was that the person's usually upright. So they're not lying down after a meal and feeling it, they're not waking up in the middle of the night feeling it, they're upright. So the acid is either shooting up the esophagus really fast, or what I've said in the past, trickling up really slowly. I just realized that the speed was not discussed, but what was discussed is that it's a brief moment that the passage happens before it then resides up into the throat and voice box, and thereby is creating the symptoms there, versus the classic reflux that comes up and kind of pools and aggravates into the lower part of the esophagus. So that's where it's pooling and hanging out and aggravating the tissues and then creating the classic symptoms. So hopefully I've described that well enough. Now, can LPR, what I'm discussing, then turn into classic acid reflux later? Absolutely. You can have both at the same time, and you can also have obviously just classic acid reflux that doesn't create any of these symptoms. So there are a few variations, but what is it misdiagnosed as most commonly? definitely allergies or infections, because it can mimic that you have like a sinusitis or something like that, because you've got that postnasal drip, which of course can be allergies, but it can also come from the sinuses. They can think it's vocal strain. There's something called anxiety-related throat tension, which some people are misdiagnosed with. So that usually the allergies and the infections is the way it goes. And the other thing that's misleading is that an endoscopy, which they classically do for the acid reflux, that can be normal with just the LPR, so just this upper area being affected. The endoscopy is normal, meaning they're not saying your esophagus is inflamed, because it isn't. You know, this acid, whether fast or slow, is just bypassing the esophagus rapidly or slowly, but it's not pooling, it's not, you know, residing there, it's getting up into the throat, and that's where the misdiagnosis comes from. But root cause is the same. We have, obviously we're getting past the lower esophageal sphincter and the upper esophageal sphincter. So what we know about increased intra-abdominal pressure is definitely there. You know, that's what's causing too much pressure on your poor little stomach, that it has no choice but to bring the acid upwards. So we've got that as a cause. The weakened sphincters, both lower and upper, most likely. And we've talked a little bit recently about the vagus nerve, which is your longest cranial nerve that comes from your brain. It goes down the front of your neck. It goes to your chest, your heart, your lungs, your diaphragm, your stomach, your esophagus, your entire gut, and your abdomen. So it's very, very busy and travels to a lot of places. Also innervates or allows to function all of these sphincters, the upper, the lower, the sphincter coming from your stomach into your small intestine, the sphincter that goes from your gallbladder and pancreas into your small intestine. So all these little valves that allow the passage of nutrients and food and drink to pass when that's needed, those are all told to work by your vagus nerve. And what we're understanding is there's a lot of vagus nerve malfunction, or as they call it, decreased tone. And that's affecting all of these sphincters and the function of all the areas that I just mentioned. So it's really important when we're creating a root cause approach is to say, okay, we understand it's the LPR, we understand all the symptoms are up here, but why? You know, that's what root cause is about. It's like, that's nice, because of course the classic treatment, I should mention, is the PPI and the H2 blockers and change your diet, and I'm not saying change your diet like it's not important, because it is, but I don't like the fact that they just focus on kind of the classic tomatoes and onions and well, chocolate can be, there's good chocolate and bad chocolate. Don't want to throw that chocolate under the bus unnecessarily, but the classic foods they tell you to avoid tend to be aggravating the condition but not causing the condition. But certainly we optimize the diet and clean up the diet as far as over processed foods, a lot of sugar. I should mention that smoking and alcohol can absolutely aggravate the function of these sphincters, so that is known. But typically that increased intra-abdominal pressure that's putting so much stress on the stomach, yes, it can be diet related, but it's not just these classic tomatoes, onions, things that are spicy. It goes beyond that. You know, gluten and dairy are some of the two most common food sensitivities that we find, and certainly neither one of them are spicy, right? It's actually what people tell you to eat. Oh, you got a lot of acid in your stomach, have some bread and, you know, let it sop it up. Not if you're gluten sensitive, then that's really not going to work. That's part of the problem. So yes, we look at the diet. Yes, we look at the health of the overall gut as far as your microbiome, the 40 to 100 trillion organisms in your gut that are either friendly bacteria or unfriendly bacteria, and you need a nice healthy balance of those bacteria in order to not have inflammation in your gut. And inflammation is a key here to create that excess intra-abdominal pressure. So it's teasing out what are the causes for you of that increased intra-abdominal pressure and inflammation. And so we have infections, we have toxins, we have diet. We're looking at all of these things, and on a structural side of things, we're looking at vagus nerve function. We're looking at how your diaphragm is functioning, because remember, as the stomach compresses and gets pulled up, what does it run into is the diaphragm. So we're looking at all these facets, and that's where we have a great deal of success treating LPR. And so I'm really glad I was asked to discuss this, because it is so often missed. And if you've been frustrated with maybe just taking antihistamines, or sometimes they even think it's asthma, but you're taking these medications and it's really not making a difference, then LPR can be the problem. Often a savvy ENT can find it, but there's also just looking at the symptoms, understanding what's been done, and sometimes it's a diagnosis of, well, we've looked, we've tried everything else and that hasn't worked, it's probably this. But then again, you're just left with, here's your PPI, and you can definitely see more videos where I talk about the dangers of PPI drugs, but they are many, and so it's not something you just want to have as your band-aid for this acid reflux, because it has so many dangerous side effects to your, well, it can create stomach cancer, it can create dementia, kidney disease, weakened bones, infections. They are severe, the side effects. So if you need to do something very temporarily, that's not the end of the world, but we have to concurrently be getting to this root cause of this increased intra-abdominal pressure and or loss of vagal nerve function. It's usually a kind of a marriage of both, and that's how we handle it. So again, I'm happy that I got to share this topic. It's not something I've spent a lot of time with before now. And by the way, if you like the channel, please subscribe. We are increasing our subscribers, and that allows more people to see the channel, which we love because we're trying to educate. And yeah, give the video a thumbs up. I answer pretty much every question I get online, so feel free to write back. That's how I learn what you want to hear more about. And I think I might include in the description a survey that we recently did of those of you who watch the videos, because we're trying to make sure what we bring to you is exactly what you want to hear about. Okay, so it's been a pleasure, and I'll talk to you soon.